Good evening, everyone. This is Dr. Kaladhar from Yashoda Hospitals, Malakpet. Welcome to our Tuesday masterclass from the Department of Critical Care Medicine, Yashoda Hospitals, in association with Hyderabad IDCCM chapter. We bring forth these master classes regularly, which are very much helpful because our senior seasoned examiners are being involved, because of which their knowledge helps to students, especially while tackling the exams like DrNB, IDCCM, and any other exam, of course, because very extensively discussed cases. And today's topic for discussion is AKI and RRT part. So especially the urosepsis part and then patient landing up in RRT, how we tackle. So for this, we have our senior seasoned examiners, Dr. Chandana Reddy, madam. She's head of the department and senior consultant at Star Hospitals, Hyderabad. Welcome and good evening.
Thank you.
So, and we have Dr. Kanwalpreet Sodhi, madam. She is director and senior consultant from Dept Hospitals, Ludhiana, Punjab. Good evening, ma'am.
Good evening.
So,
Thank you for getting us here.
Thank you, ma'am. So for this, to present the case, we have Dr. Monisha and Dr. Sahana, both are second year DrNB students from Continental Hospitals, Hyderabad. Dr. Monisha, you can start presenting your case. Yeah, you can share your screen.
Yes, sir. Is it seen, sir?
Yes. Yeah.
A very good evening. Presenting the case of a 38-year-old female who came to ER on the 29th of November at around 8:30 p.m. with complaints of back pain since 3 days, decreased urine output since 3 days, fever since 1 day, and vomiting since 1 day. To elaborate on the history, the patient presented with back pain since 3 days, localized to the left loin, non-radiating in nature, not associated with difficulty in walking, no aggravating or relieving factors. She also gave history of decreased urine output since last 3 days, associated with burning maturation, high-colored urine, increased frequency and urgency to void urine. Fever since 1 day, high-grade, intermittent in nature, associated with chills and rigor. Vomiting since 1 day, non-projectile in nature, non-bilious, containing food particles, no aggravating or relieving factors. There was no history of any rashes, loose stools, jaundice, chest pain, palpitations, fetal edema, any recent history of travel, hematuria, or trauma. Past history, the patient is a known case of type 2 diabetes mellitus since the last 5 years. She got this at the time of her pregnancy as gestation diabetes mellitus. She's on regular medications with metformin glimepiride combination twice a day, Voclivos 0.3 mg thrice a day, vildagliptin 50 mg twice a day. No significant family history. Her personal history, she had a normal sleep pattern with mixed diet, regular 5 to 30 day menstrual cycle. Her last menstrual period was on 16th of November with regular bowel habits.
Dr. Monisha, can we just okay. From the history itself, like what is your provisional, like what are you thinking about? What are the differentials you have in mind?
Ma'am, pertaining to my history, since she's a young sexually active female, she gives a history of back pain, low urine output, and fever with vomiting since 3 days, and fever since 1 day. My first differential diagnosis would be UTI, ma'am, urinary tract infection. It could also be acute appendicitis or acute abdominal conditions like acute pancreatitis, acute cholecystitis, acute pancreatitis, or torsion ovaries could also be there. Any other pelvic inflammatory disease, or acute hepatitis.
Appendix, again, left loin pain is not a typical site for appendix. Don't ever say for left side. If it's a right loin pain, I can still accept a retrocolic appendix or something. But a left loin pain, don't just think of appendicitis, nor cholecystitis. So both don't occur in the left side of the abdomen. So don't, left loin pain, you can talk about only about colitis. Colitis is a possibility. because somebody has the left this thing, or like you said, again, pancreatitis, again, tail of pancreas can present in the left loin, that area, the pain can be there. But
Renal colic.
yeah, renal colic is of course there. Renal colic,
Yes, ma'am.
urinary tract infection, then pancreatitis, if you know, tail of pancreas, rarely, or even some colitis.
Yes,
But not appendicitis and cholecystitis. They are on the right side, so you can't. It can't go. Pain can't go till the left this thing. And again, left ovarian. Okay, that is also a possibility. But again, that can also be a torsion or ovarian cyst with the rupture or hemorrhage into ovarian cyst can still cause a kind of
Yes.
pain and.
Especially she is into the sexually active age, so you have to have the history concerning the sexual
Yeah,
transmitted diseases
ectopic or
also,
something also is a possibility.
right?
So those kind
So
of
you have
things.
to ask for any pervaginal
Discharge.
secretions. Yes, discharge. So
Ectopic
that history is
pregnancy
also,
could also
Yeah,
be.
ectopic pregnancy. Yeah.
yes. So
So
yes,
LMP also is
even
important.
ectopic, we
LMP was on 16th, ma'am. She presented to the ER on 29th,
Okay.
almost 10 days back.
okay. Anything in history you feel that anything else beyond, like, because when you think about the differentials, anything else which is important?
So, you know, she has some infection somewhere. That's the first diagnostic possibility. So then what are the complications of that you try to elicit history based on history, the complications of infection that you try to elicit?
Any organ involvement, ma'am, like
Yeah.
because of severe infection in the body, if there's any organ involvement or if there is persistent hypotension, which can present in the form of dizziness or high-grade fever, or she already has decreased urine output, so yes, it could be one of the organ involvement which is already there. Altered
That will come
sensorium
to
could
when
be
we
there.
talk about the examination part. Okay, I think we can go to the examination part now. So once you have any from the history itself, you must reach a, you have the differentials in mind, and then you go with the examination. That is the most important thing, right?
Her vitals in ER on presentation, she was conscious and oriented with a GCS of 15/15. Her pulse, she was tachycardic with a pulse rate of 122 beats per minute. All the peripheral pulses were felt. There was no radial or radiofemoral delay. Her recorded blood pressure in supine position on the left upper arm was 150/80 millimeters of mercury with a respiratory rate of 18 per minute. She was found to be febrile with a recorded temperature of 101.8 degrees Fahrenheit. Her room air saturation was 98%. General physical examination, the patient was moderately built and nourished. She weighed around 64 kilograms with a height of 158 centimeters. JVP was not raised. The thyroid was normal. She was found to have mild pallor. There was no icterus, cyanosis, clubbing, lymphadenopathy, or bilateral pitting pedal edema. Systemic examination, per abdomen examination, there were no visible scars, sinuses, or pulses. There was no local rise of temperature. Her abdomen was soft with mild suprapubic tenderness. The left costovertebral angle tenderness was present. There was no organomegaly. There was no free fluid in her abdomen. Bowel sounds were regular and heard. Central nervous system examination, she had a GCS of 15/15. Her pupils were 3 mm bilaterally equal reactive to light. There were no focal neurological deficits. The power was 5/5 in all the 4 limbs. Respiratory system, bilateral equal air entry was there. There were no added sounds. Cardiovascular system, S1, S2 heard. Tachycardia noted. There were no murmurs.
One thing important is when you're talking about respiratory system, don't talk about air entry. That's only in ventilated patients you talk about air entry. You're supposed to tell about the type of breath sounds. You're not talking about a ventilated patient. Then it's okay. You talk about air entry, it's fine. But when you're talking about this thing,
normal,
you're supposed to tell about the vesicular breath sounds or bronchial breath sounds, whatever you hear. It's not about air entry. Yeah. Okay. And what will you look and how will you differentiate between a UTI here? How will you differentiate between a upper urinary tract versus a or uncomplicated UTI versus an uncomplicated UTI? How would you go about it?
Ma'am, if it is
In terms of examination and history.
Ma'am, in case of uncomplicated UTI, with respect to history, the systemic involvement is usually less, ma'am. It is more in case of complicated UTI when it ascends beyond the bladder. On examination findings, suprapubic tenderness is commonly seen in case of cystitis, but once it ascends beyond the bladder, that is when pyelonephritis or anything like complicated UTI is there, then the patient is tend to have like suprapubic, costochondral angle tenderness or renal angle tenderness is found to be more common in case of complicated UTI.
So from your examination, now you have done the examination. So now what is your provisional diagnosis?
Ma'am, based on my history and physical examination findings, my differential diagnosis boils down to more of urinary tract infection, complicated urinary tract infection.
Okay.
But
So why are you saying complicated urinary tract infection?
ma'am, she is having left costovertebral angle tenderness. So had she been having a simple cystitis, simple UTI, then there would be no involvement all the way up till the
How do you
vertebral
define
angle.
uncomplicated UTI and complicated UTI? How do you differentiate? When do you say uncomplicated UTI?
Ma'am, structurally speaking, when the infection is confined to the urinary bladder, it is simple UTI. If it extends beyond the bladder, it is complicated UTI. Pertaining to the clinical findings, if the patient presents with systemic involvement, signs and symptoms of infection, it is predominantly suggestive of complicated UTI. And previous definitions were saying that in a sexually young active female with cystitis, it was simple UTI. Anything other than that was referred to as complicated UTI. But as per the newer guidelines, it doesn't say that. But Harrison also.
So as per your patient, I have two questions. Firstly, how do you say that, what are the like corroborating findings that it's a complicated UTI? One. And what are the risk factors for the complicated UTI?
Ma'am, firstly, talking about the history, she has history of back pain, decreased urine output, and fever, predominantly suggesting that is systemic involvement. And with respect to my examination findings, she is having suprapubic tendon along with costovertebral angle tenderness. So that is also suggestive of complicated UTI. And considering her background, that she being a sexually active female, yes, ma'am, like ascending urinary tract infection is more common among
What are
young
the risk
sexually.
factors she has? She has another risk factor for complicated.
Diabetes mellitus, ma'am. She is having
Diabetes
diabetes
mellitus.
mellitus. So
And
it
it
is
also has
again
history of any
unaffected.
renal colic in the past. Any history
She
of
did
renal
not
colic or
have,
renal-
ma'am.
yeah, that's important. Any obstructive disease in the past. Yeah.
And what are the other risk factors beyond your patient? What are the other risk factors for a severe infection or the complicated UTI?
Any previous history of renal colic or nephrolithiasis, any systemic infections, such systemic metabolic disorders like diabetes mellitus, or if the patient is having chronic kidney disease, if the patient is having cardiac failure or chronic liver disease.
Is it related to
Sorry,
UTI? Like the chronic, the
ma'am.
CAD, or I personally feel no.
Structurally speaking, if there's any
Yes.
obstructive things like in a male
Obstructive
patient,
urinary tract, yes, obstruction in the urinary tract,
in a
male
male patient, it
sex,
could be yes, ma'am.
pregnancy, diabetes mellitus, any previous organ transplantation, and even sickle cell disease, or
Patient on a catheter.
the elderly age.
Neutropenic patients.
Yes, so they all are risk factors
That
for,
is-
right?
Yeah.
So in your patient, you have a diabetic patient, and you don't know, because as ma'am was saying, the previous history, past history of any previous infections or catheterization. So that is important. Right? Okay, so I think we can move ahead.
Yeah.
Now, like with this history, like what are the investigations you'll plan for? What all investigations you'll plan for?
Ma'am, first and foremost, I would want to get a urine analysis done because I am suspecting more of a UTI. So I'll get a basic blood panel done along with urine analysis with blood and urine culture sensitivity. And also I would get an
Basic blood panel?
EEG done.
What does basic blood panel include?
Complete blood count, renal function test, and liver function test.
Okay.
So what will you look for in the urine analysis? What do you want to look for?
Can I move to my slide or?
No, you tell us what you
Yes,
want to
yes.
see, what you're expecting.
Ma'am, first and foremost, the color of the urine, whether it is clear or hazy or cloudy or amber colored. Then I would also would want to see the specific gravity, the pH of the urine, the presence of any red blood cells or pus cells predominantly, or epithelial cells, any granular casts.
What do epithelial cells tell you? If there are a lot of epithelial cells, what does it tell you?
It is more suggestive of tubular damage, ma'am.
Epithelial cells.
Tubular epithelial damage, it can result in luminal obstruction.
I'm sorry, I just got a phone call. Okay. So, ma'am was asking, like, what are you looking for in the urine analysis? Can you just please, because that I personally feel is the most important part of any UTI.
Color of the urine, ma'am, and whether it is clear, cloudy, or amber color. Second is specific gravity. It will tell us about the
Okay.
osmolality of the urine. Third is pH of the urine, whether it is acidic or alkaline. Then the presence of pus cells, any RBCs, epithelial cells, the presence of any casts in the urine, and the presence of any bacteria can also be detected. And the presence of nitrites in urine,
Okay.
more important.
Anything else? What else you can have in urine routine in the patient with UTI?
Glucose, ketone bodies,
Okay.
proteinuria can be looked into.
Proteinuria, that
Glucosuria.
will signify the previous baseline renal function.
Yes,
You
ma'am.
can have even blood in the urine with UTI. You can have positive leukocyte esterase test beyond the nitrate. So if your patient has a nitrate positive, what is the suspected organism here?
Ma'am, nitrite reductors such as that of Pseudomonas or Klebsiella, E. coli.
E. coli, okay. So the most important thing I always emphasize, like especially with my students, that a basic urine analysis can tell you about numerous things. So do not just, whenever I ask most of the junior people, they just say that urine routine, it's normal, or they're pustles. That is what they just tend to look at. But there are this enormous information we can get from a urine routine analysis. Okay, so beyond this, like you have got a CBC and a RFT, LFT, and a urine analysis. What else do you want to? The investigation part.
ABG, ma'am, because she's a diabetic with high glucose levels. So ABG to know her baseline, if there's any acid base abnormality, I would want to look into ABG as
Okay.
well.
Any
And I
markers
would
of
also want
inflammation?
to
Markers of
IBS.
inflammation?
C-reactive protein levels, procalcitonin levels also I would want to send.
Okay.
I don't want procalcitonin here.
Ma'am, that will help us assess in the severity of the underlying
It does not tell us
condition.
severity. It does not tell us severity.
Progression. It will help us in antibiotic de-escalation on a later date.
Later, that's later. No, in the course of illness, you can always do a procal and stop the antibiotics. But
Indirect
it's not
marker of
required.
severity of infection.
No, it does not tell the severity of infection.
Severity, no. And how far, like, you know about the time period when the PCT gets positive? Timing from the infection. Within less than 6 hours, usually PCT is not positive, right? So yes, PCT in recent studies, it has been shown that yes, it can, very high levels of PCT can show the severity of the infection, but it is usually not seen as a marker of severity. Only for de-escalation. So when do you plan for de-escalation? If we are talking about PCT, supposedly your PCT is more than 10. You have a qualitative or a quantitative analysis for PCT in your labs?
Quantitative, ma'am.
Quantitative. Okay. Supposedly your PCT is 18. So you have started with the antibiotics. When will you plan for a de-escalation based upon the PCT?
Ma'am, PCT can be repeated after 2 days.
Okay.
And if there is a decrease in PCT by more than 90%, or if it is less than 0.25, then the antibiotic has to be stopped. If the PCT is less
But you can't stop antibiotics in 2 days for a
No, I'm
de-escalation. For de-escalation.
Here for de-escalation.
De-escalation, like based upon the PCT. We always talk about that we de-escalate our antibiotics based upon the PCT.
If there is a reduction in PCT by more than 80% compared to that of the baseline, then we can consider de-escalating the antibiotic.
Is it so? Dr. Sahana, you want to improvise?
PCT can be repeated 3 days after first PCT.
No.
First PCT value.
Yes. You can repeat after 48 or 72 hours, minimum of 48 hours. And more than 50% decrease in PCT levels from the first PCT levels you got. If there's a decrease in more than 50%, or like, yes, PCT getting normal, that is fine. Then you can always plan for a de-escalation. Okay. So I think we go ahead. Anything else you want to get done? A random blood sugar level?
Yes, ma'am. Urine ketones.
That is mandatory. Right? So, okay, you have your investigations. Now, like, let's see what you have done. Anything else beyond these investigations? Do you want to get a blood culture done?
Yes, ma'am.
Blood culture, you will get it done. Is blood culture required in all UTIs?
No, ma'am.
No. So when do you get a blood culture done in a?
In high-risk patients, like in my patient, she's non-diabetic. So yes, I would want to get a blood culture done in her case.
Okay. What are the other indications of a blood culture in a patient of UTI?
Neutropenic patients, individuals who are on immunosuppressive drugs. If there is any other
What is the positivity of like positive predictive value or sensitivity, specificity? What is the specificity, sensitivity of blood culture in a UTI patient?
I'll have to look into it, ma'am.
So blood cultures in an uncomplicated UTI usually are not required. But yes, if there's a diagnostic dilemma or you feel that your patient has been on antibiotics previously and you might not get a urine culture positive, you can go in for it. And even in a normal, uncomplicated UTI, but who is not improving, even after 72 hours of antibiotics, you can go in for a blood culture. And blood cultures usually don't come positive. More than 30-40% is the positivity. That is the blood culture positivity. So in all UTIs, you don't need a blood culture, right? Okay. So what do you have in your investigations?
Ma'am, the first ABG showed us an uncompensated high anion gap metabolic acidosis. Her ECG was suggestive of sinus tachycardia with a heart rate of more than 132 beats per minute. Her random blood sugar was 444 milligram per DL.
Okay. So
These were
can we go back to this slide? So how did you label it as? Just let us just revise. How do you say that it's a high anion gap metabolic
ma'am, her
acidosis?
pH was 7.27, ma'am, which is suggestive of acidosis. Her bicarb was 17.9, 18. So suggestive of metabolic acidosis. Applying the Winter's formula over here, the expected PaCO2 was 35 plus or minus 2. But in her case, it was 40 plus. So there is some component of respiratory component as well. And my measured anion gap was around 20, ma'am, which is suggestive of high anion gap metabolic acidosis. So
Okay.
that's
So
how
what are the causes of high anion gap metabolic acidosis?
ma'am, methanol, uremia,
What are the common things first? Don't go to methanol poisoning. How
Yes.
often do you see it?
DKA,
DK, your patient is a diabetic. You have a
diabetic,
blood sugar of 444. So the first thing you should speak out is diabetic
DKA.
What are
ketoacidosis.
the other causes in your patient? Of
Huh.
metabolic
Lactic
acidosis?
acidosis could be there, AKI could be there.
Lactic acid is
urinary
only
tract
2.2,
infection.
no? Lactic acid is only
Yes.
2.2, yeah.
AKI, no, urinary tract infection, urosepsis could be a
Sepsis.
cause for it.
Okay. So now what else you have got? You have got a RBS of 444.
Yes, ma'am.
Okay.
Next slide.
These were her set of laboratories on day 1, ma'am. The abnormal values were there was an elevation in the total leukocyte count. It was 14.2. Her urea and creatinine levels were elevated. Urea was 95 and creatinine was 2.91. Her HbA1c was 10%, ma'am, which is suggestive of uncontrolled blood sugars. Her procal was 8 and her C-reactive protein was 367.
Okay.
These were on
So now
day
you-
1.
Okay. So you now have all these investigations available. Now what is your diagnosis? Complete diagnosis I want.
Summarize your diagnosis. Yeah, tell a summary of your diagnosis. Diagnosis, yeah.
Complicated UTI with AKI and uncontrolled sugars.
Anything else you want to add?
With high anion gap metabolic acidosis.
Okay. Anything else? Complete diagnosis.
Can we say it's neurosepsis with AKI?
With AKI, AKI stage. Can we talk about the stage here?
Yes, ma'am. Going by the KDIGO criteria, she comes into stage 3.
Which stage?
Do you have a baseline creatinine?
KDIGO stage 3.
We don't have, yes, ma'am, we had a baseline creatinine. This patient had come on an OP basis to the physician's OPD for her glycemic control, and that was 3 months back. And it was showing a creat of 0.8.
0.8.
Considering that as the baseline, there's an increase by more than 3 folds.
So then it comes to stage?
Stage 3.
Okay, can we just enumerate? Can you just enumerate for the attendees basically, like what are the different stages of AKI?
Ma'am, as per the KDIGO criteria, there are 3 stages. Stage 1 is when there's an increase in serum creatinine by more than 0.3 milligram per DL over 48 hours, or with respect to urine output, less than 0.5 ml per kilogram per hour.
Per kg per hour.
Per
kg
kg
per hour.
for 6
For?
to 12 hours.
6 hours.
6 hours.
6 hours.
Stage 1 is less than 6 hours. Stage 2?
Stage 2 is when there's an increase in serum creatinine by more than 1.5 to
2 to 2.9 times the baseline, ma'am. And there will be reduction in the urine output of 0.5 ml per kg per hour for more than 12 hours. And third
Okay.
staging will be a rise in the creatinine of more than 3% from the baseline, or increase in creatinine levels of more than 4 milligram. And there is a fall in the urine output of less than 0.3 ml per kg per hour for a period of more than 24 hours, or anuria for more than 12 hours. It's defined as
Or?
stage 3.
Or
Or patient requiring a
RRT.
RRT.
patients on renal replacement therapy. They are all put in the stage 3.
Stage 3.
So can you comment upon now, because when you talk about AKI, always it's better that we put in like in what stage of AKI patient is in. So now your patient is in?
Stage 3 AKI as per KDIGO criteria.
Okay. So, and you have an uncontrolled diabetes,
Much.
right? So when you talk about your diagnosis, it should be a complete diagnosis. Uncontrolled diabetes mellitus with complicated UTI with high anion AKI stage 3 with high anion gap metabolic acidosis. And can we label it as diabetic ketoacidosis here?
Ma'am, mainly urine ketones have come negative, and we had not evaluated her serum ketones, ma'am. So at this
Okay,
point
so-
in time, it is difficult to say that she's in DK.
Do you have the urine analysis report here?
Yes, ma'am.
Okay. Okay, what
Urine
is
ketone-
more sensitive?
Sorry?
Urine ketones are more sensitive or the blood ketones?
Blood ketones, ma'am.
Okay, so should we
Which
get,
ketone is tested in the blood?
what are the 3 types of ketones?
Acetone, acetoacetate, beta hydroxybutyrate.
And
Beta
what is detected?
hydroxybutyrate levels will be detected in serum.
Beta hydroxybutyrate cannot be detected in urine, ma'am, only in serum. So that is more sensitive for DK. But in our
Okay.
patient, we did not get it done.
Okay. So what is your urine routine? Anything positive in the urine routine?
Ma'am, there was 2+ proteinuria, 4+ glycosuria, nitrites were absent, 30 to 40% were seen, and granular cars were present, ma'am. Epithelial cells were 8 to 10. And
Okay.
to begin with, it was hazy in appearance, with
Okay.
normal pH and normal specific gravity.
Okay. So you got all these reports. What was the urine output during this period?
Ma'am, initially when she came with a history of decreased urine output, but when she came to the ER, she was found in a state of dehydration, ma'am. Like she was not pouring urine output for the first 1 hour when she was in the ER. She was not catheterized at that point of time. But
So when you were putting in your examination, did you highlight that patient was dehydrated? What are the parameters you should look for when you go in for assessing the hydration status of the patient? How do you assess the hydration status?
Ma'am, first and foremost, pulse rate could be on the higher side because of dehydration, hypovolemia. BP could be on the lower side, dry tongue clinically, and decreased urine output with respect to the history.
On examination, skin turgor and capillary refill time you have to see.
Okay. So,
Any
whenever
postural
you
fall,
go in
they have
for
a
your
postural
case,
fall is also important. So postural fall in the
Social hypotension. Yes.
postural hypotension, the early sign of hypovolemia.
so when you're suspecting hypovolemia in your patient,
Cold
all
peripheral.
these parameters should be part of your examination. Right? Okay. So, what else next?
A 2D echo was done, ma'am, which showed no RWMA, normal LV function with an EF of 60%. Because the patient had severe pain and her history and examination findings were suggestive of a complicated UTI, we immediately got a CT abdomen done. And it was suggestive of the left kidney being larger in size compared to that of the right kidney. And there were multiple areas of hypoattenuations and multiple air pockets seen, ma'am. And there was significant perinephric fat standing also. All of these were suggestive of emphyse matters pyelonephritis. So there was
So,
enlarged.
what is the clinical significance of these air pockets?
In the
Gas-
indicates gas
gas
producing
form-
microorganisms.
So, what are the probable organisms you're suspecting?
E. coli, Proteus, Pseudomonas, Klebsiella, and among sometimes in fungal infections like suggestive of candida infection. These are the
What are the
most
common
gas-
organisms which cause UTI?
E. coli, Staphylococcus saprophyticus, Klebsiella, Proteus, Pseudomonas.
I think you're forgetting enterococcus is a very common organism.
Enterococcus.
Right? So, when you look at, why did you get the CT's abdomen directly? Should we have gone in for an ultrasonography or CT?
Ultrasonography.
Can we go in for a simple ultrasound?
Yes.
Ultrasound abdomen or the ultrasound KUB?
We can, ma'am, yes.
Would it have sufficed? See, if we are looking at simple UTI, what are we looking at? We want to look at the urinary tract. So, right?
Obstructive, non-obstructive.
Obstructive causes will be ruled out. But yes, CT scan is a more diagnostic pathognomic, you get the pathognomic features and you are more, that's more conclusive. And will you go in for a plain CT or a CECT?
I will go for a plain CT because she's already in AKI stage 3 and that will be subjecting her to more of contrast-induced nephropathy. So we would avoid
Minimize the
contrast exposure.
Okay.
At
So
this point.
if at all, I tell you that you have to go in for a contrast enhanced CT. So what all precautions will you take?
Adequate hydration, ma'am. First and foremost is adequate hydration. There's no proven role of
What fluid will you use for hydration? Which fluid for hydration?
0.9% normal saline can be used for hydration, ma'am. Until and unless we are not going beyond 2 to 3 liters. If we are then in concern of hypochloremic acidosis, we can go for
We
balanced
cannot give more
salt
than 2 liters,
solutions.
3 liters for a patient for contrast-induced nephropathy, to prevent contrast-induced nephropathy. So, we have to use normal
this
saline is what is
case-
studied. It's been normal saline which has been studied for preventing contrast-induced nephropathy, not any other fluid. Okay, so you should use normal saline only. Okay. And what are the conditions?
Anything
where
else you can? Yes,
Yeah.
ma'am. Sorry.
No, go ahead.
There is no proven rule for the start of NAC or statins, ma'am, but we can give it as a trial.
See, NAC has no proven rule. The only thing that can prevent as a grade 1 recommendation is only for hydration, adequate hydration with normal saline. As ma'am was highlighting, we should always, stress upon that normal saline as a preemptive measure, right? So no role of NAC. And anything else you can do? Use of isosmolar contrast. Right? So you can always recommend, because when you must have a one-to-one talk with your radiologist that this is a patient with AKI. Creatinine, obviously, they always ask for when we get a contrast-induced CT scan done, and then we can always talk about that. Please give an isosmolar contrast, right? Okay.
So when do you do
So-
imaging? Do you do imaging for all patients with UTI, or when do you think of doing imaging at the beginning, the start of illness? On day 1 of presentation, in which patients do you suggest imaging?
Ma'am, if the patient is not getting better and
It is
even
later stage.
despite
I'm saying on day one, patient comes to you on day one and you have the investigations on your hand. You're suspecting a complicated UTI, or you have to
hemodynamic
be
instability, if the patient is hemodynamically unstable, then we can go ahead with radiological
Okay.
imaging.
then what else?
In case we are suspecting some obstructive pathologies, ma'am, like
Okay.
absolute no urine output,
Okay.
and there is a significant clinical findings like her tenderness is more than she looks.
And anybody who has AKI also should go ahead. So significant worsening of her renal function compared to the baseline. So worsening renal function, septic shock or severe sepsis, or if the patient has a history of renal calculus in the past, or now you're suspecting a obstructive pathology. Okay. Or some
The
people say
diagnostic imaging.
even if you have a urinary pH of more than 7 alkaline urine, then also they recommend that you go ahead with the imaging. So these are the 4-5 indications for doing imaging on day one. And of course, the patient doesn't improve after 48 to 72 hours, definitely will go ahead with the imaging then to rule out any obstruction or any hydronephrosis or a renal correction or anything else. Okay.
So
Yeah.
imaging will be important for the source control, because you
Yes.
should always have the source control. We always talk about, when we talk about sepsis, the source control is the most important thing. If there is a source, like for this emphysematous pyelonephritis. So I think we move ahead, like with your case only, what you have
Okay.
done, let us see. So you have done the CT abdomen also. This is suggestive of emphysematous pyelonephritis. What is the, how is your case going now? What are the parameters? What you have done for this patient?
Ma'am, firstly, in the year, the patient was given adequate hydration. She was given 2000 ml fluid bolus followed by 150 ml per hour fluid with NS. Since her sugars were on the higher side, 8 units of insulin was given and she was started on high dose scale of insulin infusion. Start doses of pantoprazole, MSF, and paracetamol was given because of her clinical findings. And start dose of 3 grams of cefoperazone sulbactam combination antibiotic was given, ma'am. Post this, the patient was
Okay,
shifted to
just a minute. Okay. So you started with a 2-liter bolus of 0.9% saline. Why saline only?
Ma'am, as per the surviving sepsis guidelines, the fluid of choice for hydration or resuscitation is one.
In how much time this bolus was given? Was your patient in shock?
She wasn't, ma'am,
No.
but she looked
Okay.
dehydrated.
Okay. So you gave a bolus of 3%, 2 liters of 0.9% saline, and you followed it up with 150 mils per hour. So on what basis was this fluid given? Do you start with this much of fluid in all patients?
Ma'am, this was actually an ER where we were not in direct contact with the patient, but once the patient came to us in the ICU, we did check her IVC status, and then it was found to be collapsing. That's when we went ahead and gave another fluid bolus of 1000 ml, and then continued her hydration with 150 ml per hour. This was checked depending upon her hemodynamic parameters. Only then
Okay,
it was
what beyond the IVC you checked for the hemodynamic parameters? What did you look at specifically?
And first and foremost, her lung profile was A profile lung. So she did
Okay,
she
you're
did
comfortable then. If it's a
so
profile, you are very comfortable. Okay, what else?
But what is the indication for giving fluids here? Because what do you follow normally when you, first of all, there should be a requirement for fluid. Okay, so first
Yes.
initially IVC was collapsing, then you started fluid. But later, what is the need to continue 150 ml per hour? What is the indication to continue 150 ml per hour? There's no recommendation for maintenance fluids as such. In any case of, unless the patient is in shock and he's still fluid responsive, there's no need to give a maintenance fluid like that. What's the indication for maintenance?
Exactly, this was the question. You are not suspecting a decay. You told me that this patient is not in decay. So on what basis you gave this 150 mils per hour fluid? What other parameters? Okay, you didn't have the A profile. You were having the A profile on the lung ultrasound. What else did you look for? Your patient was never in shock.
no.
Heart rate?
Tachycardia was there, ma'am.
Tachycardia was there.
Fever also.
Tachycardia,
Fever, yeah.
122
Fever
was the
was-
baseline heart rate.
Yes.
Okay. So you not mentioned what is the heart rate now. Your patient is anuric.
She was oliguric, ma'am. She continued
What
to
was
have
the urine output?
per hour. Did you put a Foley's catheter and then monitor her
Yes,
output hourly?
yes, ma'am.
Yeah. So what is
Yes.
the output per hour approximately? In the first
Ma'am,
8 hours after she came to the
on-
ICU.
From the time we received the patient to ICU, she was catheterized in the ER and then shifted to the ICU. She was pouring around 10 to 15 ml per hour only. And she presented to us in the night. The very next day morning, urology referral was kept and patient was taken up for DJ stenting. Post that, she started pouring good amount of urine, ma'am, like around 40 to 60 ml per hour she was pouring. From
What
the
happened to
second
lactates?
Just a second. Before the patient went for DJ stenting, right? So how much fluid you have given? You have given her 3 liters of bolus and 150 ml. Your patient went for DJ stenting on day 2. Your patient is hardly pouring out 10-15 ml. That's not clear from the slides, but yes, okay. You're saying that he was pouring out around 10-15 ml of urine per hour, right? And you're giving 150 ml per hour. So what all you can expect? What are the complications of giving this fluid?
fluid overload could have happened because of her non-functioning kidneys. Assuming that she's having non-functioning kidneys, it can result in fluid overload, ma'am. But this was constantly monitored and only then given.
Okay. Okay.
Like,
So
what are the complications
then,
of fluid overload? What are the complications you expect of fluid overload?
Pulmonary edema.
Okay. What else?
that you are ruling out from you had your lung ultrasound done. What else can happen with this much of fluid?
Administration of normal saline may cause hyperchloremic metabolism.
Okay, so
What
it can further complicate your metabolic acidosis. What else? Anything specifically, something more to do with your patient?
How does it affect the renal function? further?
Intra-abdominal hypertension. Your patient can land up into abdominal compartment syndrome, and it can further, hamper the kidney function, and AKI can worsen further. Even intra-abdominal hypertension can be a sole cause of
Worsening
AKI.
renal function. Yeah.
Right? So you have to be very particular because you cannot just keep on continuing with this much of fluid. You need to mention like what was the heart rate, how your patient is behaving with fluid. Okay, for initial few hours, okay, I agree that your patient was dehydrated. You gave a fluid bolus. You started with this much of fluid, but you cannot, for an anuric patient, you cannot continue with this much of fluids.
You also should follow the lactates also. Lactates also will help you
Yes.
guide whether the fluids are sufficient.
Lactates are the very good parameters. That's the best parameter, easily available
Your
in all your
patient's lactates are
EGGs.
not very high. It was only 2.2.
2.2, ma'am.
And she was not in shock. So there's really absolutely, I don't think there's any reason to continue so much of fluids. Okay, that can
Okay.
cause further complications like abdominal hypertension and abdominal compartment syndrome, which can worsen your outcomes. Okay.
So you started with this antibiotic,
Yes, ma'am.
ceftriaxone sulbactam. On what basis? What was your basis on what you started with your antibiotic? Usually it's a very simple question, like on what basis we plan about if we have any patient, on what basis we decide our antibiotic.
So what are the common organisms which you find in complicated UTI? Emphysema, pyelonephritis, what are the
So
organisms? And
how
based on
did you decide the antibiotic? Why not something else?
We have to, most common organisms will be E. coli, Pseudomonas. Pseudomonas coverage is also important. And we have to expect the ASBL producing organisms also. So based on that, we have to choose the antibiotic coverage.
So basically antibiotics are decided based upon like what organisms you are suspecting. So mainly you suspect a gram-negative septicemia because that's a UTI, except for the enterococcus or the staph if we have a separate thing. And the specific organ involved, right? So you started with this dose. You gave a 3 gram bolus and you started with 1.5 gram PD. Any modification you should do for your patient?
Renal dose adjustments has to be done based on the creatinine clearance.
This
Okay.
was done the very next day, ma'am. Like on the second day, the antibiotic was actually escalated because she continued to be febrile And we had not yet placed the DJ stent. So the moment we, like on day 2, we escalated the antibiotic to meropenem.
Just
2
based
grams.
upon that patient is febrile, you will escalate your
There was
antibiotic?
an increase in the total count as well, ma'am. It had
Okay.
increased from
Okay.
14,000 to 24,000. And the
Okay.
patient was quite tachycardic and septic features, like
Yes.
that she looked, so the source control was not yet done. So we escalated the antibiotic to meropenem. As per the
Okay.
creatinine clearance, was 29, her creatinine clearance. So
Okay.
we gave her 2 gram Stantos followed by 1 gram BD. And then she was taken
Normally,
up to the
do we normally modify the antibiotic dose in the first 48 hours? Even if the patient
ma'am,
has
loading dose, we do not modify, but yes, the follow-up doses.
even the maintenance dose in the first 24, what do we expect in a patient with sepsis? What happens?
What happens is,
The
Even
volume of
what
distribution
are the
is
drug factors that affect the clearance of a drug? What are the basic parameters which affect the clearance, drug
volume of
clearance?
distribution, ma'am.
Okay. So
Yes,
what
in
happens to the volume of distribution in a septic patient?
it is less.
It is less.
Less.
Okay, what are the other factors? Let us just talk about what factors affect what are the drug characteristics which affect the drug clearance? Volume of distribution,
PKPD of the drug.
protein binding. PKPD is based upon like the volume of distribution, the protein
It
binding,
defines
the
PKPD.
molecular size of the drug, right? So they all basically affect, and the clearance, whether it's a hepatic clearance or a renal clearance. So based upon the hydrophilic drugs, usually they are the ones which are cleared through the kidneys, right? So what happens is basically, since these hydrophilic drugs, they have a small volume of distribution, right? So once we have a increase in the volume of distribution, right? So we need to give a loading dose always. Remember, in any patient with AKI, loading dose should always be given. Principle number 1. This always has to be remembered. You just cannot bypass this for any drug, right? So loading dose has to be given, and usually patients need higher maintenance dose, right? Because the volume of distribution has increased further. So initial 48 hours, please do not generally, except for the patient is on RRT, we'll talk about it later, but do not, decrease the dose initially. So always give a loading dose, let the plasma levels be, attained, the concentration levels, what we need to attain. So let it be there. And then we have to keep in mind the whether patient is on RRT or not, then we talk about it further, right? So the drug clearance should always be in mind that, and especially in the initial hours with so much of, if your patient is hemodynamically unstable and patient is into sepsis, so it's better that you give a higher, give a loading dose and a higher maintenance dose, right?
And second thing is, whether it's time dependent or concentration dependent killing. So your carbapenems and all these things are all time dependent killing. So you have to give more frequent dosages, not 1 gram. Even if you're reducing the dose later or after 48 hours, it has to be maybe 5 mg TID rather than giving 12th hourly dose. Understand? So that's also important. So whenever you decrease the dose, you decrease it according to the same dose. Between dose interval should be maintained. You should not increase the dosing interval. You should rather decrease the dose rather than increasing the dosing interval in time-dependent antibiotics. Okay, like carbapenems especially. So even late after 48 hours.
And what is the expected GFR if the patient is anuric? Whatsoever the creatinine level may be. Because we always we say that use this formula, that formula, all the formulas, how many times we're using the formulas for creatinine clearance in our ICUs routinely. So generally an anuric patient usually has a GFR of less than 10, right? But again, the same thing, that initially do not decrease the dose, right? So with RRT, there's a separate thing. When we talk about the renal replacement therapies, then we can talk about the drug clearance once again, right? Because drug dosing in patients of AKI is very important, right? So we ought to know that the hydrophilic drugs and the hydrophobic drugs. Hydrophobic drugs usually do not have this renal clearance. So they do not get altered, but almost all the antibiotics we use in our ICUs day in, day out, they're usually cleared through the kidney. They are usually hydrophilic, so they do need the drug modifications, but no skipping of the loading dose. Right? Okay. So, one thing was we talked about that you had to, you had escalated the antibiotic based upon your clinical condition and the TLC counts, right? Okay. Next, what else you got?
Ma'am, on day 3, we got our culture reports, ma'am, wherein the urine an MDR E. coli was isolated with coliform count of more than 10 power 5.
How do you say MDR?
What is the significance of this colony form count?
Sorry, sir, ma'am.
What is the significance of the colony count in a urine culture?
In order to say it is bacteriuria or it is significant, it
How
has
much
to be more
how
than
much
10
count?
5.
Does the count matters when we interpret the urine culture report?
Yes, more than 10 to the power 5 colony form units per annum.
For a catheterized patient.
Yes.
So colony count, always look at the colony count. If it is less than 10.4, that means it is not a culture, like it's not a urinary tract infection. Right?
Contamination.
Colonizer, contamination. Right? And how do you interpret this?
How do you say MDR? Why are you saying MDR?
Ma'am, for it to be MDR, at least one drug resistance in 3 categories it has to be resistant to.
Okay. Yeah, which 3 drugs it's resistant to? Which 3 groups?
Fluoroquinolones, cephalosporins, ma'am.
Okay. Cephalosporins,
Fluoroquinolones, ma'am.
fluoroquinolones.
And trimethoprim
Sulfamethoxam.
Oh, okay. So how do you interpret this report? Is it ESBL or it is carbapenem? What do you say? How do you say it's ESBL?
ESBL resistant. It's sensitive to cefoperazone and sulbactam. And to carbapenems also it is sensitive.
If it's resistant, you should ceftazidime or cefepime. If it's resistant to those drugs, then you label it as
Yes.
ESBL. Yes.
So based on this, and her blood and urine culture were sensitive, sterile, ma'am. So we
Can we go back to the same, just your culture report? Okay. So even your fosfomycin is sensitive in this report. So can you use fosfomycin for this patient? Fosfomycin is a good drug for UTI or not?
It is a good drug, ma'am, but she underwent a urological procedure. So
okay.
We would
no, otherwise, I'm just asking, not in this patient. Can you use fosfomycin for such a complicated UTI?
Fosfomycins are usually administered as oral single dosing. So since it's
Can we use it in this case? Can we use it in this case instead of meropenem or not? That's what ma'am is asking.
Sometimes some intrinsic resistance patterns can be observed with E. coli infection for fosfomycin.
We're sensitive here. It is sensitive here.
Sensitive, this is a sensitive drug. If you look at
the diabetic
bottom, the 4th drug
under high risk.
Just for your information, nitrofurantoin and fosfomycin are very good drugs for UTI, right? But these drugs do not attain adequate renal tissue concentration. So do not use it for pyelonephritis. For acute pyelonephritis, these 2 drugs do not have any indication. You might have seen the nephrologist people, prescribing these on OPD basis a lot. NFTs and fosfomycin is a drug which is like oral medicines are used, but they do not have adequate renal tissue concentration is not achieved, right? So these are not the drugs to be used for a complicated UTI, especially for the pyelonephritis. Okay. So
how do you manage a patient?
Do you want to de-escalate based upon this urine culture report? Should you de-escalate?
We did de-escalate, ma'am, actually. We de-escalated the antibiotic to piperacillin tazobactam.
So initially you started with ceftriaxone sulbactam, you shifted to, on day 2, you shifted to meropenem, and then day 3, you are using piperacillin tazobactam. Is it justifiable?
If
Actually, source
In
control has been
emphysema pyelonephritis, how do you treat a patient of emphysema pyelonephritis? It's not a simple pyelonephritis. It's an emphysema pyelonephritis. And how do you stage it? How do you stage emphysema pyelonephritis? And how do you treat it?
according to Johansson classification, ma'am, we'll be
What is it?
staging into
This
class
patient is which stage?
fourth stage.
Which grade?
class 2, ma'am.
Two. Here the perinephric correction also, no? Perinephric, spread into perinephric space also.
Yes, class 3.
Yeah, class 3. So class 3, do you just do a DS stenting and stop with it and then you de-escalate the antibiotics? Is it safe to do that?
Source control has been achieved.
Source
Initially,
control has been achieved. I know.
Parallel, how does parallel space get drained by a DJ stent? DJ stents only drains if it's in the pelvic ulcer system. It's only stage 1 or stage 2, grade 2. It will drain with the DJ stent. Once it crosses the kidney, it won't drain with the DJ stent alone. You have to do a percutaneous or a PCN or a percutaneous drainage has to be done of the parallel space. Then only you can treat the patient appropriately. Okay.
On day 4, there was significant reduction in her total leukocyte count, the urea and creatinine levels. The patient was hemodynamically stable, pouring good amount of urine up to 40 to 80 ml per hour. The IV fluids were stopped. Piperacillin tazobactam antibiotic was continued. On day 4, she actually complained of pain abdomen, ma'am, like in the left loin again. So a repeat CT scan was done. It showed the left DJ stent was in situ. And with comparison to the scan which was done on the 29th of November, the first CT scan, there was significant reduction in the size of the kidney. The perinephric fat standing was reduced and the M5C matrix changes or the air pockets were completely resolved. So after the CT, she was only given some painkiller with paracetamol. And so this was a CT abdomen one, which showed that left DJ stent was in situ. So on day 5, she was hemodynamically stable, clinically better. Her total leukocyte counts had reduced. Urea and creatinine were downtrending, pouring good amount of urine. So she was shifted to the ward.
Okay. So nicely managed. This case was okay. You got in for the source control and you had a good, the patient started pouring out urine and your creatinine eventually started decreasing, right? So if at all, we talk about day 1 itself, right? Your patient was anuric, right? Your creatinine was 2.91. So is there any indication for giving diuretics? One thing. Should you have given diuretics here?
Ma'am,
A challenge, dietary challenge. No,
Your
fluids.
patient is anuric, no?
Oliguric, ma'am. My patient was oliguric.
Oliguric.
You said, yeah, okay.
Okay.
Such a patient will give
So-
dietary challenge.
What is the difference between oliguria and how do you define oliguria? How do you define anuria?
Oliguria is when the urine output is less than 400 ml per day in 24 hours, and anuria is when it is less than
50
15.
ml in 24 hours.
Okay. So should you have given a shot of diuretic?
After
Yes,
hydration.
ma'am, we could have given a furosemide challenge test.
Furosemide challenge test. Okay. So what is furosemide challenge test?
In
What
a
is that? Stress-
diuretic patient, that is in a patient who has not been previously exposed to diuretic, we can give furosemide in a dose of 1 milligram per kilogram. Or in a previously diuretic exposed patient, we can give it in a dose of 1.5 milligram per kilogram. And following this, if there's an increase in urine output by 200 ml in 2 hours, then the patient is said to be diuretic responsive. Then in an adequately hydrated patient, we can go ahead and give diuretic and assist for improvement
So
in
the
renal output.
prerequisite for FSD is basically that the patient has to be hydrated,
Adequately
right?
hydrated.
Adequately hydrated. So does this diuretic challenge make a difference to the outcomes?
Ma'am, ask
Start the
trial.
Yes.
What does the positive test tell you? Say if a patient responds to your Fruit challenge, what does it tell you? Does it tell you anything about the prognosis? Outcome?
Ma'am, that the patient is still in the pre-renal AKI stage and we can give
Should you give for a prerenal patient?
Oh, not
Should you
renal.
give a diuretic challenge to a patient who is in prerenal AKI?
No, ma'am.
No, absolutely no. That is a contraindication. So just 2 minutes back, we talked about that for giving a diuretic challenge, your patient has to be adequately hydrated. Hydration has to be adequate. So prerenal AKI is a contraindication for performing an FST, right? One thing. But I was asking, supposedly you have a FST positive. That means that after giving a diuretic challenge of 1 milligram per kg or 1.5 milligram per kg, your urine output was more than 200 mils in the next 2 hours. Subsequent 2 hours, patient had poured out 200 mils of urine. So does it make any difference to the outcomes?
Or your
Yes,
management?
it does. It means that the kidneys are still functional, ma'am. They are pouring good amount of urine, so they are still responsive. So intervention
Yes,
at this
they
point
do
of
tell
time
us
can
about the
help you
tubular
better
function.
function.
Right. So, but you are converting a patient of oliguria to a non-oliguric phase. That does not eventually, all the studies have shown that it does not make any significance difference to the outcomes in patients. Converting a patient from an oliguric to a non-oliguric state, it does not make any difference, right? So yes, it does tell you that still the tubular function of the kidneys is good. There is, available tubular function, so patient might respond. And I think everybody in the ICUs, they don't exactly give, but if you want to give a diuretic challenge, my suggestion will be always go in for a FST with the adequate dose. Don't underdose, because diuretics don't work when especially the kidney function is not normal. The underdosing of diuretics doesn't work at all. But it should not, it should be clear in your minds that it does not make any difference to the outcomes at all, right? Okay, one thing. So if at all you gave up FST, right, the oliguria did not improve. The FST was negative. Then what would have been your further approach? Should you have gone in for renal replacement therapy? Any role of renal replacement therapy at that point of time?
If there's worsening metabolic acidosis or her hemodynamic status, then yes, ma'am, RRT will be the treatment of choice at this point of time.
What are the indications for doing RRT?
Refractory hyperkalemia, refractory metabolic acidosis, volume overload, not responding to the medical management, uremia resulting in encephalopathy or uremic pericarditis. These are the indications for that.
These are the absolute indications.
Yeah, absolute
right?
indications.
So if it is a refractory metabolic acidosis or refractory hyperkalemia or refractory fluid overload. So this was why I was stressing upon that. Why did you give so much of fluid? Your patient can go into fluid overload, right? So if there's a worsening acidosis not responding to the treatment per se, so you can go in for a renal replacement therapy. Right? Okay.
Would you give bicarbonate?
Because
if a patient had metabolic acidosis, would you give bicarb to the patient before going for RRT?
do you give bicarbonate at any point of time? I think ma'am wants to ask specifically, like, any role of bicarb therapy here?
Not very sure, ma'am. Okay.
Bicarb can be administered as a method of delaying the renal replacement, need for renal replacement therapy in case of which. And in case of severe lactic acidosis, bicarb administration. For delaying the renal replacement therapy, we can use bicarb.
With renal replacement therapy, why?
There is no such observed indication bicarb administration bicarbonate.
No, that will be that you're talking about the replacement fluids.
No,
What are you talking about? Sorry, I didn't get it.
No, ma'am. In modality to delay the renal replacement therapy.
To delay, she's saying, not for, along with the bicarb, you're not, along with the RRT, you're not saying.
No, ma'am.
Okay. She's saying only to delay it, you can give it, but there's
Okay.
no definite role, as I know, it's still controversial. Giving bicarb. Unless the page, immediately just before starting an RRT, you can give it till you start your RRT, but not as a definite treatment.
Yes.
Okay.
So you have the absolute indications of RRT. What are the, if we talk about we have to complete the RRT part also. So what are the relative indications of renal replacement therapy? Not for this patient specifically.
Toxin removal in case of certain drug toxicity, such as
What
that,
are the toxins which are removed by the RRT?
isoniazid, salicylates, atenolol, uh, barbiturates, lithium, ethanol,
Lithium, alcohols, perfect, salicylates.
dabigatran.
Okay. Right. Okay. So what are the other relative indications of RRT?
If blood urine nitrogen is more than 100 milligram per deciliter, and in case of oliguria and anuria, in case of rhabdomyolysis, in tumor lysis syndrome, these are all the relative indications.
Tumor lysis syndrome, and even for these days
Rhabdomyolysis.
extracorporeal therapy for the
Extracorporeal.
sepsis,
Yes, ma'am.
right? Okay.
Hypercalcemia, those are the indications. Somebody has
Yes,
hypercalcemia.
Right. So what are the different modalities of renal replacement therapy available?
now we have got intermittent hemodialysis and continuous hemodialysis. In intermittent hemodialysis, we have
There is a continuous renal replacement therapy and prompt intermittent renal replacement therapy. Continuous renal replacement therapy, we have a continuous veno-venous hemofiltration, hemodialysis, and hemodiafiltration. And in intermittent modalities, we have intermittent hemodialysis, sustained low efficiency daily dialysis, and a single scuff now. So continuous filtration.
Okay. So basically we can divide based upon the duration, the intermittent, the continuous, or the hybrid therapies, and based upon the mechanism of solute removal. So what are the different mechanisms of solute removal for the
diffusion, adsorption, convection, and
Ultrafiltration.
ultrafiltration.
okay.
Solid is
So
not
based
ultrafiltration.
upon
For solid, you can't say
Sorry?
ultrafiltration. Ultrafiltration is only for fluid. Huh?
ultrafiltration is a convection only,
Convection.
right?
Yeah.
Because in convection, what we do is we drag the solutes along with the
Solvent
plasma.
drag.
After we apply a positive hydrostatic pressure, so the solutes are basically dragged along with the water, right? But in ultrafiltration, only the water is being filtered across the
Okay.
semi-permeable membrane. So scuff is like ultrafiltration is basically a convection only, right? So what is primarily removed through the diffusion? If we talk about diffusion, what are
Small
the
molecule
molecules?
clearance.
Small molecule clearance is better with diffusion. Although small molecules can also be cleared through a convection also, right? But for larger molecules, which is a better modality?
Adsorption.
For better
Continuously.
modality is filtration only. Convection we use for larger molecules, right? And especially for the molecules like cytokines or all these, they are better
That's
removed by the convection, right? So
In which
scuff,
modality, in which conditions do you prefer CRRT or continuous modality over a intermittent modality?
When
In
the
a case of
patient is
sepsis, like you have a sepsis
unstable-
patient here. Yes.
hemodynamically unstable patient now, like the
Okay.
rapid fluid shifts can result in worsening of the condition. We would prefer continuous renal replacement. Like
Which are the conditions? Which are the conditions?
In hemodynamic instability, ma'am.
Yeah, that's
Or in
already
case
said,
of
already said that.
liver failure, and if there are signs of raising ICP, sepsis, which is requiring a toxin removal, septic shock. So these are
for
the
toxin
indications.
removal, do you prefer CRRT?
Toxins or cytotoxins?
intermittent
No.
hemodialysis.
Toxin
Rapid
removal,
removal.
yes.
Endotoxins and cytokines.
Yeah,
Toxins
endotoxins,
rapidly
okay,
remove.
yes. Yes.
Endotoxin removal.
And even for hypernatremia, it is better that we go in for a slow, decrease
Yes,
in
ma'am.
the sodium levels. So CRITs are better.
Hypo or hyperactive, both ways. The
Yes.
slower correction happens in the patient. The CRRT
Sodium,
compared
when we want to correct the sodium, CRIT is a better modality. When we want to correct the potassium, then the intermittent hemodialysis is a better modality, because potassium within first 1 to 2 hours, it is cleared from the blood, right?
And even for
So-
things like a large volumes, you want to remove over 24 hours. So the amount of nutrition we're giving or the fluids we're giving, you want to remove all the excess fluid. And also the CRRT is better because you can remove 1 to 150 ml per hour, 200 ml per hour we can remove over a period of 1 day or 1 to 2 days. We can remove a large amount of fluid compared to a intermittent hemodialysis. Yeah. Okay. So
what are the problems with continuous renal replacement therapy?
Ma'am, anticoagulation requirement will be is predominantly present, ma'am, because filter clogging is one important thing that we'll have to look into. So anticoagulation is one. Nutritional supplementation, because there'll be a lot
Nutritional
of
supplementation is rather very
Better in
much,
general.
it is better with CRRT.
you
We can meet the nutritional requirements in a much better way with CRRT rather than with the intermittent hemodialysis. So this is not a disadvantage of CRRT.
Cost effectiveness will be CRRT. We should have a separate machine for CRRT. It's not like
and
unlike
Yes.
the
IHT
training
and
required to
and
set up this
it is very
also.
costly compared to the traditional
apart from
dialysis.
that,
So it's more labor intensive, more economic. The costing is more, resources are both the human as well as the machine availability is there, and we cannot mobilize the patient.
patient
Right.
cannot-
Patient cannot be mobilized. Okay.
And which electrolyte is
Do you use CRRT?
Yes, ma'am.
Okay. So if you don't have a CRRT modality with you, you have done your DrNB, you have shifted to a periphery institute. So what will you do? You have a dialysis machine with you.
SLED can be attempted, ma'am. Low efficiency.
So can you use
Daily
slide for the same IHT machine? Can you do slide on the
Yes, ma'am. Yes.
how?
The effluent rate adjustment will be there.
With a slower blood flow rates and the dialysis flow rates, you can have you can
The same
decrease the
thing
blood
can
flow
be-
rates and you can, right? So because when you want to do a dialysis, basically what do you said? You said the blood flow rates, you said the dialysis
Dialytic
flow rates. Right?
Alpha
So what is the
filtration.
difference between the blood flow rates and the dialysis flow rates?
In
in normal intermittent hemodialysis.
Otherwise,
Oh, okay.
in hemodialysis, we have a blood flow and a dialysis flow.
Compared to
In which directions do they go?
opposite direction is
Opposite directions. That is known as a counter current direction. Counter current flow. What is the advantage of counter current flow?
faster removal of the solutes, ma'am.
So the
Rapid
solvent
removal
removal
of
is
solute.
much rapid when you have a counter current, right? You can have in the same direction also, but counter current flow is much better,
Rapid
right? Okay. And in convection, what is the extra thing like for the CRRT? In CRRT, whatsoever, is cleared, like the solutes and the plasma, they are basically just removed. So you need to add a replacement fluid,
Replacement fluid is required. Yes.
right? So replacement fluid has to be added. You know that about the different, you can be asked about, why we are focusing on this masterclass, basically because this usually does not come as a separate case. The RRT and the AKI part doesn't come as a separate case for the students mostly, but almost for all patients, every type of patient, they ultimately land into the acute kidney injury. All type of patients, be it a septic shock, be it anything, a trauma patient or sepsis patients, every patient can go into AKI. So at some point of time, you will surely have a viva in any of the cases on AKI and renal replacement therapy. So you have to be well versed, these days, because RRT is coming up hugely in almost, I think every good ICU has a CRRT, but although 50% still do not have a CRRT, but SLED is a routine thing in the normal ICUs these days. So you must be, well acclimatized with the RRT thing, because for sure you'll have a Viva on AKI and RRT, right?
So what about
Other cases,
hypertension? Sorry.
Yes,
No,
ma'am.
go ahead. Yeah, no, go ahead.
no, it's okay.
No, hypertension during dialysis. You're doing a dialysis for a patient in the ICU, and the patient develops hypertension during dialysis. So how do you deal with it, and how do you try to prevent it? How can you prevent development of hypertension? Because it's very important. We face it very often, day in and day out.
The rate of ultrafiltration removal can be reduced, ma'am. One thing. In case we are supposed to remove and we are bound to remove it, a small dose of vasopressor infusion can be supplemented at that point of time during dialysis.
What else? What else can be done?
Replacement fluid depending upon the mode of dialysis.
No, we're talking about intermittent hemodialysis.
The
Maybe
duration of
No, we're forced to do a SLED or a IHD. We cannot afford a CRRT. You have to manage with this.
duration can be increased, ma'am.
Okay, duration can be increased. Blood flows can be decreased.
Blood flow can be decreased.
And the sodium content of the fluid, you can increase sodium content. There's a lesser fall in the
Yes, ma'am.
hypotension. You can give IV albumin. Either
Yes,
if you have the
replacement
you can
fluid.
give pre and during the intra-dialytic time, you can give some albumin. And they say even the temperature of if you can maintain slightly higher temperature of the dialysis fluid, if you increase the temperature of the dialysis fluid, also you can decrease the frequency of these episodes. Okay, and of course you can use some vasopressors like you suggested. So all these things can be used to prevent or decrease the incidence of hypotension during dialysis episode. And even high calcium dialysis can be used to prevent the hypotension. These are all some of the things that have been tried and found to be useful. Okay. What
What
are
are the different types of anticoagulation?
We can go ahead with unfractionated heparin, low molecular weight heparin, or direct thrombin inhibitors, ma'am.
Okay.
This comes under systemic anticoagulation. There is a regional anticoagulation, etc.
Okay. So when should you plan for how do you plan for anticoagulation? On what basis you plan for your anticoagulation?
Depending upon the mode of dialysis that we are choosing, if it is intermittent hemodialysis, then if the patient is having any bleeding diathesis or coagulopathy, then the patient need not be put upon anticoagulation one. And
But then
but in
what
case
do
the
you
patient
want
has
if you don't want to give any anticoagulation, what all can you do to prevent the coagulation?
saline flushes can be used
Okay.
to prevent it.
Priming the circuit previously before the initiation of dialysis with 1,000 to 4,000 units of heparin. That can be done.
Okay.
And the intermittent flushing of saline can be done. And we have to check whether the air filters are tight so that air trapping does not occur.
Yes. And the types of cannulas, they all also affect, because basically you have to prevent stasis of the blood, right? So you must have in mind that you should have a good vascular access to prevent stasis. If you don't want to use anticoagulation, then more so it is very important. Otherwise also, but so the cannulation part, the access, right? So there should not be angulations in the cannulas. So yes, they all are. And as ma'am was saying, that the air in the circuits, everything has to be, taken care of, not only the coagulation part. Okay, so one thing is flushes, saline flushes. Next is heparin. How much heparin you give? Unfractionated heparin when we talk about.
For intermittent hemodialysis, 10 to 20 units per kilogram, followed by 5 units per hour infusion.
Okay.
Till the time of
So
death.
routinely you're using this. Then how do you monitor it?
APTT monitoring should be done.
What is the target of APTT?
Okay, right.
35 to 45 in case of unfractionated heparin.
Yeah. Then what is the target for APTT? 1.5 to 2 times. Right? So you have to, and how frequently you get it done?
We'll do a 4th hourly monitoring. 4 to 6 hourly monitoring.
4 to 6 hours. Okay. Okay. So then you can go in for a unfractionated heparin, or you go in for a regional citrate anticoagulation, right? And there's a thing called regional heparin anticoagulation also. Are you aware about it?
Yes, ma'am. Like when we Before infusing the blood back to the patient, protamine can be given.
Protamine, yes. Because similarly, as we use the RCA, we can give heparin, right? And post-filter, we can give the
Post-filter we can
protamine
give.
such that into the systemic circulation, the anticoagulant doesn't go, right?
Definitely.
So if we talk about regional citrate anticoagulation, what is the benefit of RCA?
Ma'am, calcium, citrate is, it chelates calcium, ma'am. Ionized calcium is chelated. So the coagulation pathway is obstructed at that point of time. The advantage with it is
No systemic manifestations will be there. There will be a propensity of bleeding will be comparatively compared to the other systemic anticoagulation, it is less more.
What else? What is the most
And
important?
citrate will be converted into metabolic acidosis. One molecule of citrate will be converted to three molecules of bicarbonate. So in case of metabolic acidosis, additionally bicarb supplementation will be helpful in when we are using citrate.
More important than all this?
sorry, ma'am.
What is the filter?
I couldn't-
What is the importance of citrate anticoagulation with regard to the filter life?
It
It will
prolongs the
prolong
filter life.
the filter life.
Yeah,
And
so
Most of the
we do.
studies have shown that the filter life is
Bleeding that-
prolonged, right? So there is a benefit, but what is the disadvantage?
Metabolic alkalosis, hypocalcemia are the predominant disadvantages of using regional citrate anticoagulation.
You
And
can have
also
both
the-
metabolic acidosis as well as alkalosis.
Anything
Yes,
else
ma'am.
to say?
Depending upon the citrate toxicity or citrate not.
Yes.
In which
yes,
patients?
yes.
In which patients will this happen? Citrate toxicity.
Citrate toxicity is in
In which group of patients are you worried about citrate toxicity?
In conditions of liver failure.
So,
Citrate is basically metabolized in the liver,
Liver.
right? And so what another disadvantage, major disadvantage is frequent calcium monitoring is required.
ionized calcium.
Hypocalcemia is a very, very common problem with this. So you need to monitor both the post-filter citrate as well as the systemic calcium levels. Sorry, post-filter
Ionized.
calcium levels as the ionized calcium levels and the blood calcium levels, right?
what are the
So,
complications you monitor for in a patient with the CRRT? On CRRT, what are all things you will monitor on a daily basis, or how do you assess the efficacy of CRRT and also the complications? Look for complications in the CRRT patient. Anybody?
Electrolyte
Okay.
disturbances, hypercalcemia, hypomagnesemia, hypophosphatemia has to be looked into. Coagulation,
Any bleeding manifestations and the patency of the filter.
How do you assess the patency of filter?
Plotting membrane pressures over the CRRT machine. Monitor the membrane pressures.
CRRT machine or the filter?
if the filter is clogged, then the pressures will
What is it called? What are the pressures called?
transmembrane pressure.
What else will you monitor? Platelet counts are falling. What do you think? What do you do?
If a patient is on systemic anticoagulation, we have to suspect. If heparin anticoagulation is going, then heparin-induced thrombocytopenia might be a
Has to
probable
be-
cause of thrombocytopenia.
What are the complications? Okay, I think we'll go on. Anything else, ma'am? You want to ask?
So
Dr. Sodhi?
complications.
Yeah.
Yes, ma'am. I think we have covered most of the part. Anything else, Dr. Kaladhar, you want to add
Yeah,
upon?
I think we have,
When do you stop? Yeah, Dr. Kaladhar, one more thing. Just when do you stop? Say, patient you also already started an RRT. How do you decide that okay, now RRT the patient doesn't require RRT any longer, and you want to switch back to either continue with the conservative management? When do you stop RRT? Once you start RRT for a patient in ICU with sepsis, when do you stop?
When the primary concern for which we had started RRT has been addressed, when the urine output is more than 400 ml, is pouring good amount of urine, then yes, we can consider weaning from CRRT.
And if
RRT.
you
More than how much per day? No, how much urine per day?
10 to 20 ml. 10 to 20,
That's it. There are different criteria laid down by the guidelines. So what do the criteria say?
400.
More than 500 ml per day
Urine output.
without diuretics, or more than 2 liters with diuretics.
With diabetes.
That's one criteria. What else?
Hemodynamic stability has been mentioned. Okay.
No, you're not doing dialysis for hemodynamic instability, no? You're doing it for RRT. So one is output. Second is no signs of any volume overload. The patient should not have any significant volume overload. And then your electrolytes, like your potassium, should be less than 6.
Yes.
Yeah, and your bicarb should be at least more than 15. Okay, then if the summary criteria are fulfilled, then probably you can consider stopping dialysis and seeing the patient. If again the patient does any of these indications, you can restart or you can again do a dialysis. So what these are things you can see when stop the dialysis and see whether the patient is tolerating without dialysis or not. Okay. So it's very important for us to know when to start, when to stop, and how to monitor a patient while on dialysis. Okay.
Even, de-escalating therapy from CRRT to SLED or intermittent hemodialysis, because patient might need, if you stop CRRT, patient might need subsequent intermittent hemodialysis as we go ahead. And then as the patient improves, subsequently you can wean off the patient. And patients usually, they do require, even post ICU discharge, patients do require a renal replacement therapy because they take at least 4 to 6 weeks for recovery. Right. So, okay. Anything else we want to, Dr.
Yeah,
I think
fairly we extensively covered, I think, the topic. It was a very nice discussion. So I think there are
one more thing I'd like to add, Kaladhar, that even after the AKI, it's very important to prognosticate the attendance. A lot of them will ask you, what are the chances of recovery of my patient? Will they require long-term dialysis? Will they go into CKD? A lot of questions are asked by the patient when they tell them about dialysis in the first place. So we should be aware that a lot of patients with AKI can develop CKD in the long run.
Yes,
what percentage may require line dialysis, and for how long they may require dialysis in the acute phase. So all these things we need to be clear, because attendants are very, they need to be informed about all these things. And they need to follow up with a nephrologist subsequent to discharge from the ICU if they've had an AKI episode. Because subsequent follow-up of the patient is very important to prevent them from going into or decrease the risk of them going into CKD. Okay, so they need to follow the urine examination, they need to follow their creatinine regular intervals, and prevent because they have a higher risk of cardiovascular mortality in terms of stroke and hypertension and other peripheral vascular diseases. Everything can develop more frequently in patients who have an episode of AKI, irrespective of their other comorbidities. So it's a very important problem in the ICU, which can lead to long-term problems. So we need to prognosticate the family attendants to follow up closely with either nephrologist in the follow-up. That's a very important thing for AKI right now.
And always they should be discharged on follow-up to the nephrologist.
Yeah, that's important.
That is mandatory, because the critical care physicians can only, manage the acute part, but further follow-up, because further, if they at all go into the CKD, so they have to be managed by the nephrologist, right?
So the more severe the grade of AKI and the longer the AKI lasts, the more likely to have
more is the chance of going
CKD
into
development or other complications developing in the long run. So we can always guide the attendants and the family and the patient himself to have a more closer follow-up if they had a severe persistent AKI during the hospital stay. So very important for us to prognosticate them also. Okay.
So we have few questions which I have tried to answer as we go, because already I think we have covered many things. One difference between clotting and clogging. Basically, clotting is like when a liquid thing, it gets converted into like the blood clotting occurs, right? It gets converted into a solid thing. Clogging is basically something solid particle. It gets, accumulated at a particular place. So clotting and clogging, ultimately, the mechanism is different, but ultimately the impact is the same. So we have to, look at that if the transmembrane pressures are rising, or we have to, because troubleshooting of RRT is itself a complete topic. So we have to just look. Clotting we can prevent. Clogging as such is not prevented, except for that we have the, safety mechanisms in the CRT machine itself, which can prevent the clogging things. And then somebody was asking about the cytosorb. Cytosorb I had just already mentioned, and the answers that cytosorb is a specific, it's a membrane which is available and specifically absorbs the cytokines used in cytokine storms, and it is many people are using, they are routinely using also for patients who are in septic shock, but the studies, they do not demonstrate any difference in the outcomes. That's the mortality. Although the hemodynamic benefits have been observed for the initial 24 to 48 hours, but ultimately no outcomes are changed for the patients who are in septic shock. So this is an evolving thing. Basically, many, not only the cytosorb, there's a toramexin available. Sapphire is just being now available in 2024. So many things are coming up, but the basics of, basically the diffusion, the convection, and the absorption. They are the basically absorptive filters which are available, all these things. So they are still into not proven benefits, but investigational, they are being used at many centers. But I personally, I don't know about my other experts, but I personally don't. I have used cytosorb in many patients, but I have not found any benefit in the outcomes of the patients.
Yeah, yes, ma'am. So I think, we covered extensively the topic, right from urosepsis to AKI pod. The final conclusions, ma'am. Basically, Chandana, ma'am, what are the tips or suggestions that you give to DrNB students while they are appearing for exams? See, they get this type of case, and there will be discussion going on. Any specific suggestions, ma'am? How to, like, there are many number of final year students who are going to appear as for their practicals probably in a month or something. So then probably.
First, we started from the history. So whenever you get a case of any sepsis, so first you need to identify the focus. So patient presents you with features of sepsis in the form of fever or decreased urine output and all these things. You try to look for the focus of infection. That's very important. And then once you look for the focus of infection, the second thing is you are sure it's infection, then look for the complications of infection in terms of other organ involvement is there or not, in terms of shock, renal failure, respiratory failure, any liver dysfunction, any coagulopathy. So you look for the other organ involvement. And then, of course, the patient has shock, because that itself is a separate thing. So any case, I think systematically, if you start from the history with the examination findings and the complications you're expecting, always get a differential diagnosis, at least possible etiologies you should consider. When you take any case, either it may be respiratory case, it may be a renal thing, whatever it is, you need to see a possible diagnosis, 1, 2, 3, you note it down, and you try to rule out based on your history, examination, and the investigations. And always summarize your investigations. Whenever you have all the set of investigations, you have all entire plethora of investigations, you see what are all the positives, negatives, you summarize the investigations, and then you see a final diagnosis you should have, involving all the parameters. So including the investigations, examination findings, everything should be summarized, and you have a probable diagnosis and the complications of the patient. Then all the issues that the patient has, one by one, you try to deal with the issues, starting from the most important one to the less important one. So respiratory failure, shock, they're the first important sensorium. These are the first 3 important things. So you deal with that first, and then you try to look for the focus of infection. Then you try to treat the infection. Then you go one by one, the organ failure you manage. I think going in a systematic manner helps. And always at every level, think of the differential diagnosis. What are the possibilities? What are the problems you're facing with the patient? Then deal one by one.
Yes, ma'am. Kanwalpreet madam, any specific approach in answering the questions probably? Because real time as exam goes, they will be having a bit less time only most of the times. So do you suggest any specific approach or something like that?
Sorry?
Yeah, Kanwalpreet ma'am. Basically, from DrNB student perspective, while they are there in the exam, do you recommend any specific approach in answering the questions posed by the examiner in the exam? Because most of the time they will be allotted around half an hour for the exam. As we discussed, around 1.5 hours this case. But actually in the exam, they will be having a less time. So any specific approach you can
Yeah. Approach has to be very specific. When we are trying to answer, we have to, like what Dr. Reddy was saying, that we have to, recapitulate everything, and we have to put it into, when we talk about the diagnosis, it has to be a complete diagnosis in a one go, such that the examiner will not keep on asking you, like, what else, what else, what else. It has to be, you have to put out all your findings, positive findings, along with the, like, provisional diagnosis you have reached. It has to be a complete thing, because based upon that only your further viva will go ahead. And whatsoever you talk about, please be very specific, brief, and to the point. If you talk about anticoagulation, just start like this, that you can have a regional or a systemic. For systemic, you can have a heparin or whatsoever, like just keep on enumerating. Similarly, if you talk about the modalities of RRT, so they can be based upon the duration, based upon the solute clearance, or the mechanism of solute clearance. So that ways it will be, more effective. And the examiner also, they have lesser time to ask you things, because otherwise they just stick to one thing, and ultimately the examiner is lost.
That's true.
Right?
That's
so
true.
We have to be very specific. And when you just go through the case, just summarize everything. And especially, like, if we are specifically talking about AKI, you should be very specific. You should know, like, in what stage your patient, because if you're talking about AKI, you have to enumerate that what stage patient is in. Like, so what are the things you, like in your case, you never mentioned about the urine output. Like, per hour, we should mention that this was the urine output. Specifically for this case, I'm talking. But similarly, the important things, what are the positive findings in your patient, that should be, like 1, 2, 3, you should be enumerating. And please be very specific. Don't beat about the bush, because the examiner straight away comes to know. If you don't know the answer, you should be very frank about, sorry, ma'am, I have not like seen such patient, or I have not. If you're not using CRRT, nobody will expect you to know the deeper aspects of CRRT. You can say that we are using SLED, because no study has ever shown that SLED is inferior to CRRT. So you can just put it like that, sir, I have never used, I have read about CRRT, but I don't know the practical details about CRRT, because I'm using SLED. So be open to that. That is a personal experience. I always feel comfortable, because somebody who's using SLED and never used CRRT, they will not know the intricacies of CRRT. So my personal advice is that you can always say, because the modalities which say that there's no difference. Right?
Yeah. Yes. Yeah. Yeah. Very good. Okay, ma'am. Thank you very much, Dr. Chandana Reddy ma'am and Dr. Kanwalpreet ma'am, for sharing your valuable insights and your clinical expertise and knowledge. It really helped a lot. I think probably the students and all, specifically, they will be very much whatever you shared. And thank you, Dr. Monisha and Dr. Sahana, for bringing out this case, of which we had an extensive discussion. Probably it is very good. So overall, I think I thank my branding and digital team for providing the platform, Yashoda Hospitals and Hyderabad IDCCM. So we will be bringing these very regular sessions which are helpful to the students. Thank you, ma'am.
Thank you so much. Like, it's an honor for me to be here. And I would like to just use this platform. We are having a RRT workshop in the Critical Care 2024 at Kolkata. So
Yes.
as I invite all the students, because we have only 15 seats left, we are restricting the RRT. I'm the lead for the RRT workshop for the ICCM Critical Care. So if at all you wish to learn further the details, intricacies of RRT, you're most welcome to join us for the RRT workshop at Kolkata. Thank you so much. Thank you, Dr. Kaladhar, and
Thank you,
Dr.
Kaladhar.
Monisha and Dr. Sahana.
Yeah, thank you, Chandana.
And the entire team of Yashoda. Thank you.
Yeah, yes, ma'am. Thank you, ma'am.
Okay.
Good night.
Good night. Yeah.